So good afternoon, everybody. I'm really thrilled to introduce Dr. Jason Hoppe today, who will be giving grand rounds. I think everybody knows Dr. Hoppe well, but just in case you don't, he's an associate professor of emergency medicine, faculty in the Department of Emergency Medicine, as well as the Poison Center. A renowned, internationally acclaimed toxicologist who specializes in opioid addiction and research. Dr. Hoppe attended Denison University, followed by New York College of Osteopathic Medicine, completed his residency in emergency medicine at Kings County Hospital Center, followed by a fellowship at the Rocky Mountain Poison and Drug Center. Dr. Hoppe today is going to talk to us about the opioid crisis and what's next for healthcare. One of the things that is very striking to me about Dr. Hoppe's research is that it feels as though it's almost immediately applicable. And when I think about investigators in our department, Jason always comes to mind as someone who has directly, almost immediately influenced my practice and the practice of our colleagues, both locally and nationally, for the better, obviously. And I often find myself thinking about all the patients that I've treated before I met Dr. Hoppe and the harm that I had done. So I'm thankful that Jason has done his research in the way that he is doing it, which is immediately applicable and combating one of the greatest crises of our generation. So with that, I'd like to turn it over to Dr. Perman, who will serve as moderator today. And she has prepared an interpretive dance to start off the event. Thank you, Dr. Perman.
Thanks, Dr. Zane. No dance for today. I have a bum knee, so we're going to sit that one out. But I just want to welcome everyone to today's session. I'm going to be moderating the session. I'd like to ask, as we move along, if you have any questions, to please use the chat function below on your Zoom screen. Everybody is muted, and so if you use that chat function to ask questions, I'll make sure to relay those questions to Dr. Hoppe. Dr. Hoppe would like to try and field a few questions as we move through the talk. So as questions come to you, please make sure that you put them in there, because we will be taking kind of regularly scheduled little breaks so that he can address some issues as we go. We will try and have time for everyone's questions, and we'll do our best to get to all of the pressing issues as Dr. Hoppe proceeds. So after Dr. Zane's wonderful introduction, I won't delay anything, and I will hand over the floor to Dr. Hoppe.
We're going to talk about the crisis and things I mentioned that we should talk about, but won't have time. Next, please. This is where we are historically. The worst place, as I mentioned, we've been in years, 80,000 deaths at least. These are underreported, as would be expected. About 75% of those are opioid related. Next, please. And this is Colorado. Similar trend, similar problems, probably a lot of it due to COVID. Next. And this is us in COVID. So we recently published and polled the number of excess overdose ED visits. And you can see UC Health in the top right corner there, and some of the other programs that we work with. So we've been directly affected, and our system specifically is seeing these patients. Next, please. And historically, you can see some of the other unintentional causes of death where we've made really tremendous progress over the last 20 years, whereas poisoning, including opioids, we're going the wrong direction. Next. And decreasing life expectancy. So in the pre-COVID times, this was the first time that US life expectancy went down since the Spanish flu in 1918. So the historically bad impacts, and just to put things in perspective, although now COVID obviously has changed the way that we look at life expectancy. Next, please. And the economic impact is really hard to quantify. I put motor vehicle collisions there just to give you an idea of where we're at. This is one estimate. I would say this is on the higher end. It's really hard to roll these together, right? And I bring this up just to remind us that everything we've showed so far have been deaths, and that's just the tip of the iceberg. There's a lot of other people suffering beneath that Below the deaths, the people that have chronic opioid use disorder or opioid use disorder, chronic pain who are on opioids, their families. Next, please. And so this is hopefully looks familiar to people. I'm going to show you this twice. The first time is just to look at that light blue line. That's us. That's the medical community. Really important takeaways from this, I think, are one, is we have leveled off prescribing. But two, we're still nowhere near where we were previously. So there is lasting effects of all of the changes to prescribing and the external influences. We really haven't gotten back anywhere near where we were before. Next, please. And so the first takeaway point for this is as far as motivating us to change the way we practice, is that we, the medical community, were a causative factor in this. It's amazing how long it took us to realize this and get data, but you can see here the direct relationship between prescriptions, sales, deaths, and treatment admissions. And that was just the first few years before any of the heroin or anything else hit the market. Next, please. And so the summary of We Screwed Up, a short timeline for those of you who are new to this area. Porter and Jick was a one paragraph in the New England Journal that got 608 citations and was used to really promote the low risk of addiction. Had a lot of patients, but they were all hospitalized patients and really didn't have much follow-up. Portnoy was the opioids for non-cancer pain. The fifth vital sign and JCO were policy things that were used to try and promote the treatment of pain with the right intentions, but probably not enough evaluation plan and or data collection. Buprenorphine's been available since 2000, so you're gonna hear about that today. It's an old medicine that's been around a while. And then you can see in there that the CDC prescribing guidelines are the other major real push that try to counteract some of these issues. Next, please. And prescribing is still an issue. So we're not going to talk a ton about prescribing the rest of this talk, but just to know, this is Colorado. Prescription opioids still a major issue here. So it would not be the same curve for the Northeast or the West Coast, but just know that even though we're doing a better job overall, that prescription opioid deaths are still have a higher count than either meth and or heroin in Colorado. Next, please. And so the second part of this is we've leveled off our contribution, but the deaths continue to rise. And that is most of that's due to fentanyl. And so for those of you who don't know much about fentanyl, next please, outside of the medical setting, this is a famous slide, has a lot of information here. Most important being is the small amount, right? So the difference between heroin coming from the Middle East, some from South America, some of that's the size, how much is required to get into the country, the purification of it. Fentanyl can be made in the lab, typically Eastern Europe or China, can be sent in the US mail, can be ordered on the dark web or lots of other places in the internet. And you can see the small amount necessary there, and that's a lethal dose. So you can imagine the quality control on the way to the United States, and then how this is mixed in, not really knowing what the people who have an opioid use disorder, they don't know what they're getting, and we don't know what they're getting. And I will say that fentanyl's also found its way into lots of other street medications that are counterfeit as well. Next, please. And again, the heroin supply has pretty much turned into a fentanyl supply. So you can see over time, most of the heroin, the testing that they do for deaths is no longer heroin, it's all fentanyl. And that's particularly true on the East Coast, and we're starting to see that here as well. Next, please. So we have an epidemic, we have fentanyl, right, which we know, people don't know what they're getting. We know it's very lethal. And so we're gonna move on to talk about treatment, because to be honest, we'd rather have people who have an opioid use disorder on anything rather than roll the dice with fentanyl. So I think we'll skip questions here just to keep moving. That's the Porter and Jick paper. That's it. Okay, so intervention. So where do we go from here? Well, as I said, prescribing still a problem, but really have heavily invested in prescribing and not made as much of a dent as we would like. But looking forward and projecting out, really most of the work that needs to be done is in the field of illicit opioids and getting treatment to people to protect them. Next. And so I think first ask here is to commit to prescribing buprenorphine. This is both a system and provider issue. On the system side, we really need to mobilize resources to really offload providers to allow them to do the right thing. And we'll talk about the implementation part of it in a second, but the commitment across the system is the first thing, right? We need to have the same messaging from the top to the bottom as we do for lots of other things. Sepsis, stroke alerts, all of those things that we have invested heavily in. Your chances of dying a year after a STEMI are the same as your chances of dying after an ED visit for an opioid overdose. Yet the relationship between the investment of those two, they're not even close, right? And so the second part of that outside of the investment is really reframing our focus to think of addiction and opioid use disorder as a mainstream issue and a chronic illness, the same as we think about diabetes or COPD or anything else. All of those chronic conditions have ups and downs. Patients get off their medications. Patients don't take their medications. We don't punish them. We don't fire them from practice for doing so, right? We have empathy and patience with chronic disease, and opioid use disorder should be treated the same way. The part that a lot of people don't like to hear is who's going to do this. And a lot of this is going to fall on emergency departments to identify people in need, get them set up with treatment, and then the primary care community, which we'll talk about a little bit more, to really take on a lot of that burden. Although I think that the amount of work is going to be a lot less than it seems up front. Next, please. And so we have evidence-based treatment. We don't have access to it. I'll talk about the evidence in a second, but 5% of ED patients, I told you, who receive naloxone will be dead the next year, yet only about 5% of EDs offer buprenorphine. That's a huge treatment gap. This is an opportunity to get patients who's really often their only interactions with the ED because they don't have established providers, they don't have insurance. And so we have a population in need, which we're not delivering an evidence-based practice to. Most people who need OUD treatment don't get it, depending who you believe, 20 to 40%. And I'll show you some Colorado numbers in a second. And many counties don't even have the option. And so patients are forced to drive hundreds of miles just to get to the local provider. Next, please. This is a map from a couple of years ago. That white swath in the middle is the lack of treatment access. That's 0 buprenorphine providers. Some of that is Colorado, but a lot of that would overlap with some pretty concerning maps about overdose deaths. Next, please. This is Colorado. This I encourage you to read. This is really good work from the Department of Family Medicine on the Practice Innovation Project. And I chose this one just to sort of bring about the idea of mainstreaming this. So when you look at this is the number of additional providers needed in order to close the treatment gap if the average person saw 8 patients. So this is not a massive change in the way that we see patients. This is keeping your patients in your practice. This is taking on some patients that are stabilized, keeping them in your practice. Most of that area of need is right where UC Health is, right? This is our corridor. This is the Front Range. 85% of the population of the state is here. And so there's lots of opportunities for our system to make massive gains by just changing the way that we implement and who we encourage and support to provide treatment. Next, please. And who's going to do that? Well, it's not methadone programs. So methadone programs are federally funded, and they have certain criteria in order to start, and they're not growing. So that's a fixed resource. You can see initially when buprenorphine was made available, there was a lot of early adopters, and things have kind of leveled off as far as growth. And so we have a couple of reasons to be cautiously optimistic that we can increase the amount of access due to some recent regulatory changes, which I'll talk about in a second. Next, please. I don't have time to go through all of the benefits. A lot of these will be from methadone. Methadone's been around a long time and has a lot more data. Buprenorphine, really, we're still collecting a lot of the long-term outcomes. But on this list, you'll see benefits for patients, benefits for families, society, health systems, retention in programs, so long-term as well as short-term benefits as well. The flip side of that coin of not treating, so abstinence for opioid use disorder has a yearly relapse rate somewhere around 90%. So we know that the treatment available has significant long-term impacts and benefits for everybody. Not treating really is not an option in this case. Next, please. So let's demystify buprenorphine a bit. I feel as the champion for buprenorphine in our department that every time I get the opportunity to talk about it, I'm going to talk about it a little bit. And so hopefully we can keep driving this home. So this may be reviewed for some people, but buprenorphine is not a new medication. It's been around since the 70s. It's used as an analgesic and probably will continue to be used, and actually more, I think, as we get away from some of the traditional opioid agonists. It was FDA approved for treatment in 2002, and then we've had several generic versions. And the interesting one is the sub-Q implant. The initial one, you had to be loaded first. The newer one, which I think is still an investigational new drug, you can give an oral dose, give the sub-Q dose, and then they're good for 2 to 4 weeks. And you can imagine the potential implications there for populations that are hard to risk, that are homeless or don't have access to care elsewhere, especially patients coming out of the prison system, right, being covered. And we know that leaving prison and having an opioid use disorder, leaving prison is a huge risk factor because you go back to potentially using the same doses with no tolerance. And so that would be an ideal situation to cover patients. And then next, please. So 3 things to take away. Hopefully this is review, but number 1, buprenorphine is a partial agonist. That term is sometimes confusing to people, but I think the graph on the right is very helpful. So a pure agonist, fentanyl, morphine, as you take more and more dose, you get more and more agonism until you're at 100%, or clinically, you stop breathing. Buprenorphine, as you get more and more, at some point you've occupied your receptors and you've maximized the amount of agonism you're going to get, and more drug does not equal more effect. And so that has a lot of positive benefits for us on the treatment side, as well as being a harm reduction technique. So let's think about those. So if you, the main 2 other considerations I think that apply here are, 1, if you're at 0, so naloxone is a pure antagonist, has no activity. If you're at 0 down there and you take buprenorphine, it is an agonist. So children who get into buprenorphine need to come to the hospital. So even though it's safe, and you will hear us talk about how safe it is all the time, for somebody who's totally naive and small, and this is a massive dose, they need to go to the hospital every time. The second thing to consider is that you see the maximum agonists of fentanyl and morphine. If you live there and I give you buprenorphine, I will make you feel bad because we are going to induce withdrawal. So people that live at high amounts really need to be in pretty significant withdrawal, and we have to do what we can to make them feel better before we start buprenorphine. Because, next please. Buprenorphine has a higher affinity for the receptor. So this is a relative way of measuring how much a receptor likes a ligand, or in this case, a medication. And so the lower the number, the more the receptor would prefer to have that. And so if given the choice between buprenorphine and methadone, your body, the receptors, are going to choose buprenorphine. And so this is protective. On the one hand, if you are on a steady dose of buprenorphine and you have an incident where you use fentanyl, use heroin, you will not get as much euphoria because those receptors are blocked, and B, you will not die. As I said before, you have to remember though, if you're on the time we get into trouble is if you're on methadone, which has a really long duration of action, and you may look like you're in terrible withdrawal, and we give you buprenorphine, you're going to still knock off that methadone and preferentially have buprenorphine. And so that's where we really get into trouble. Methadone is the one exception as to when to think twice about starting people on buprenorphine and asking for help. Next, please. The third thing is that it works fast. So if you're in an office setting and you want to make somebody feel better and you hold their opioids and they come in and they're in withdrawal, you can give them a dose, have them go weigh themselves or go to the bathroom, and you come back and you're going to see the effect pretty quickly. And so you can redose pretty quickly and find a happy dose for the patient that they can comply with in a pretty short period of time. It also can be broken up throughout the day. At higher doses, it lasts longer. This is really all for the OUD treatment side of it. If you're using it as an analgesic, the analgesic properties are much shorter. And so then it really needs to be split out throughout the day. The other potential use here is if somebody uses can be loaded on a higher dose, they can have more time where we know that they're protected, like over a weekend or something like that. Although what I'm going to talk about next alleviates some of those issues. Next, please. Before we get there, emergency departments. So there are, I talked about the lack of data for what we did as opioid prescribing and what started this epidemic. We now have randomized controlled trials in multiple settings, inpatient, outpatient, and emergency departments as far as long-term benefit. Here we see proportionate treatment at 30 days, buprenorphine being superior to just being given a referral or even a facilitated brief intervention. Next, please. And this led us to our own program. So there is local experience here. These numbers, as you can tell, are a month or so old, but over the first couple of years, we've started about 360 patients on buprenorphine. These are patients mostly not within our system. And I bring that up because we have a very low bar harm reduction approach. On the last one, you saw that the follow-up was 80%. That's the randomized controlled trial with pretty strict inclusion criteria. We take everybody. We've refused about 5 patients. Most of those were repeated times where their reported motivation didn't line up with what they were actually doing. We got follow-up on a lot of them, on most of them rather, and about 50% show up at that first visit and 45% are in at 30 days. These are pretty comparable to other local rates, again, with a population that potentially wouldn't be included in some of the other ones, but it's really important, we feel, to give patients the opportunity. It's also been shown the more time you get exposed to buprenorphine, or even if you use buprenorphine in the street, that you're more likely to be successful in the future, which also makes sense. Next, please. So the late breaking news is that everybody can now prescribe buprenorphine, or almost. So what's been removed by the Biden administration and what was attempted to be done by Trump on the way out is that they have removed the need for the class. So you do not need to take the full 8 hours or 24 hours for APPs and nurse practitioners. And you don't need to promise that you have the other resources available. That was part of the previous training. You can treat up to 30 patients at a time. So earlier we said 8 patients as a reasonable average number. And here we're talking out to 30. And so the important thing is 30 at a time. If I'm in the emergency department and I write a prescription for 5 days to get someone to their next appointment, when that 5 days is up, that is no longer my patient. And so you can continue to write short prescriptions to cover many patients. This is the way you do it. It's pretty easy. There's only a couple steps. It's a little clunky. The main thing to take away if you haven't done it before is that it asks you for a certification qualification. And usually that's that you took the class, but here it's just practice guidelines. And then 45 days later, you get an email saying you're able to do it. If you've never done it before, really all you have to do is the beginning of your DEA number, you put an X there and the pharmacist can check. So please spread the word, let anybody else know, please send questions. Really, this is a major lift for removing bureaucratic obstacles. I will tell you that there are 2 other bills that would permanently get rid of this that are going through, would make a positive change for the long term. But as you know, that process takes a long time. Next, please. So OUD treatment in general does reach the quadruple aim for healthcare. So we have the ability to offer a new treatment, which improves the clinician experience, right? For a long time, at least in emergency medicine, we've had a population of patients who feel terrible that we have nothing to offer them. It's a pretty, as I said, it works fast. It's a pretty immediate improvement for both the patient and for the staff. The patient outcomes are proven. As I mentioned, there are significant societal and public health outcomes that are positive as well. And the patient's experience has been amazing. We've had so many patients come in who said that they were seen in other emergency departments that couldn't help them. We've had patients bring back their entire families to get initiated, their friends. And so it's been a pretty positive experience for the patients as well. The cost effectiveness connection is a little harder to make, but there's some face validity there. Pretty much if you save one endocarditis admission to the hospital, that would pay for an entire program, just sort of the low-hanging fruit there. Next, please. So I wanted to stop. I think we have time to stop despite our delayed start or technical issues, to see if anybody has issues, concerns about what we said about buprenorphine.
So I'll ask a question if that's okay.
Yeah.
So Dr. Hoppe, as you were discussing the benefits of buprenorphine and the patient population, I'm just curious, is this replacing methadone? Does methadone still have a role in OUD treatment, or is that going to go by the wayside?
Yeah, good question. Methadone still has a role for sure. Methadone has a long history of success, but comes with additional regulations such as direct observational therapy. And so there will be a role for patients who really need that. We don't actually put that sorting hat on people in the emergency department. I'm not sure that it's appropriate to do that with our level of experience, but patients in the hospital that got seen by addiction services will often get started on them. Typically, our approach is to give, unless there's a real red flag, to give them an opportunity of buprenorphine first. But just know that emergency departments and clinics should not be starting methadone for opioid use disorder. Really, that's only in the methadone treatment programs. Methadone will always have a role, and a lot of people really thrive in that, and they just need a little bit more structure, or they fail to buprenorphine for other reasons outside of the OUD, it's the addiction itself.
Great, thanks. A comment from Dr. Lavonis. He says, I thought doing buprenorphine treatment on demand was important, but going to be an annoyance. Quite the opposite. It's one of the most rewarding things I do in my practice.
Yeah, thanks, Eric. I mean, I've heard that a lot. That's been my personal experience as well. Just thinking back to my residency and early practice, not really being able to do anything for anyone except throw a cocktail of medications at them that I know is going to wear off soon. This has really been a practice-changing improvement for emergency medicine providers and our patients as well. So I appreciate that comment. Okay, next, please. So the implementation gap. So we have a high priority issue, right, with an evidence-based intervention or interventions, depending which issue you're talking about. It needs to be implemented in a wide variety of practices as soon as possible. And this kind of goes back to what Rich said in the beginning, is really how do we change the gap from 17 years, which is what's often quoted from the time of discovery to actually reaching the patient. How do we shorten that time? And we're going to talk about sort of the approach that we've taken here. Next, please. So that is to invest in making EHRs part of the solution. I know whenever we say EHRs or clinical decision support, a lot of providers automatically flinch because they've been the bane of our existence for years. But I would argue that we need to make the most of them, and they have a lot of promise as an implementation strategy, right? There are small things that we can do to optimize our workflows as we get better at them and improve delivery of evidence-based practices. There's also an opportunity to offload providers, right? We always think of clinical decision support equals more work, but I think there's an opportunity to do a lot of stuff in the background and provide it in the right situation, the right setting at the right time for providers to improve their care. Next, please. And so this is, I think, applicable to all technologies, but particularly to EHRs, which is, it was going to be the best thing since sliced bread. Now it sucks. It's a time suck. I don't really get anything out of it, but I put a lot into it, to somewhere, depending where you are in this curve, to actually maximizing the productivity. So it's a reminder that this process does not happen overnight. It does require some patience, and it does require significant investment from the system itself, and then expertise, both internal and external as well, in order to get to that spot, that sweet spot. Next, please. So how have we been operating with clinical decision support? So mostly small changes, right? We're not making massive changes here, keeping it in people's workflow and putting it just in time. Most of the previous behavior change things are really distal to what we're doing on a day-to-day basis. It's hard to take an educational class about buprenorphine and then 6 months later, the first time you use it, feel comfortable with that. But if we put it in your workflow, then we have the opportunity to either remind you or help you go in the right direction. Scalability is huge. I put at the bottom there what the last numbers I could find for UC Health System. It's a massive number of patients that we potentially could impact and improve their lives. And doing it through the EHR really gives us that scalability very quickly. And it's also modifiable. So I'll show you the example of COVID in a second, but I think that that's been a great example. COVID really, we needed to immediately disseminate new information to people and providers in multiple settings who didn't know anything about it. And the evidence changed sort of on a day-to-day basis. But that modifiability allows it to be sustainable as well. If we get new information about a risk factor, as long as we update that knowledge source, we have the potential to make lasting changes as well. Next, please. Here's COVID. I unofficially pulled this off our dashboard, but you can see it's automatic. It's already become the most used. This is just the emergency department, the most used pathway. And you can see the utilization there kind of probably reflect our patient population. I think this is a great example of bringing people, making the most of a bad situation, but bringing people to a workflow change that they can start to appreciate as a way of modifying practice. Next, please. And if we compare that to OUD, it's surprising that we haven't done more, right? So we took new medications we didn't know anything about that had no evidence, and we immediately put them in play and delivered them to patients. Versus OUD, we have proven medications with a long history of success. We've removed the regulatory and education requirements, and still we're not delivering that practice. Next, please. So what are the benefits? Quickly here, it allows us to do things within our workflow. So everything that we build, we try not to alter the way that providers typically work, right? If you don't take people out of your workflow, do you put it in the right situation? Then we're talking 1 or 2 clicks to have a positive benefit versus leaving your workflow going to outside systems. It also can take care of a lot of variability. So knowing not all of us work in the exact same workflow. And so there are access issues to information and education that can be closed with CDS, and can also help with communication with patients as well. Importantly, long-term machine learning has the potential to make this even much better. I mean, I think of CDS as training a dog to do one trick, and they can do that one trick well if you do a really good job. But if you have machine learning, then the machine itself can learn and can learn more tricks without us having to spend all the time to do that one trick. Next, please. Depending where you are on this spectrum, you can see sort of, if you've been practicing a long time, how things change. We're probably not down to number 10, but we do have lots of functions that the computers are doing on their own, and that can offload us. There are a lot of things that we don't need to double check that could be double checked for us. I'm not sure if we'll get to the point where they decide everything. Hopefully not, but it's an important tool to help providers spend the time on the cognitive decisions they should be spending their time on. Next, please. Lots of barriers, lots of time sunk into it, particularly in the United States compared to other countries, competing demands, navigational issues, outdated knowledge, right? Are we de-implementing things that no longer work or no longer appropriate? Alert fatigue, huge issue. What's the right number? Nobody quite knows. It sort of depends on how important the issue is, what your perspective is, right? I would think that we should be alerting lots of people if we're going to pick up an opioid use disorder that's new, because we know that there's massive downstream benefits versus somebody may argue that that's too interruptive for their workflow. Next, please. So the next step in that process that we're working on that I wanted to share and always get feedback on is nudging, right? So a lot of people are familiar with the idea of nudge, but most of what we do is really just about choice architecture that's doing small modifications to alter behaviors. So it's not coercive, it's not telling you exactly what you have to do. It allows choice, but it can be used to counteract bias and align with best practices. Next, please. So here's an example of the pyramid, right? So at the bottom there is an information gap. Let's close that gap. We can do that either asynchronously or within the workflow itself. If you assume people are rational and they can weigh the risks, benefits, then we can frame that information in a way like a decision tool that we can implement proven decision tools to provide information to providers and patients. Up there at the top, start to recognize that there is bias, there are distractions, multitasking, contextual issues going on, cognitive errors. So once you get higher to the top, then we start talking about nudging. What can we do to make it easier to do the right thing without interrupting your workflow? Next, please. Here's an example. So variability in opioid prescribing from the emergency department for ankle sprains. So there's no reason to believe that it's appropriate to have 2.8% in one state and 40% in another state. That is, poor quality care. So how can we get rid of that high variability? Next, please. And this is something we've done here too, but this is the original publication. So defaults. So rather than saying for a certain condition, here's the number of pills that should be prescribed. This is in the ED, but I will tell you there's a huge push, particularly in Michigan, saying a gallbladder equals 12 pills, right? An appendix equals 18 pills, and coming up with those right numbers based on patient-reported outcomes and use so that we can drive care in the right direction. Next, please. Here's a list of some of the projects we're working on here. Order facilitators, defaults I mentioned, prompting clinical pathways. So that's a knowledge gap. If you didn't know we had a clinical pathway about COVID and a COVID patient came in, then we should push you towards that pathway. Dashboards about your actions. This is something else that could be pretty easily abstracted from the EHR, right? How do you compare to your peers, right? We're not talking about audit and feedback like in sepsis, you missed this lactate or you missed this fluid bolus. We're saying, here, we don't have a best practice, but here's how all of your peers with similar training practice, and you are in line with that or not in line with that. And there's good evidence that if you let people know that they're not consistent with social norms, that they actually change their practice. Medication swaps is what Sean, Michael, and I are working on right now. That's the idea that, well, maybe opioids are not the first choice for discharge medications. And if you're choosing that as the first choice, we should be reminding you that it's not the first choice and instead offering other choices that are more acceptable that are alternatives. And doing that so that you don't have to leave your workflow and you don't need to go find them. Everything is right there in the same screen for you. And then the PDMP check, which I'll talk about, and anybody who works here clinically has probably seen, I'll talk about in a second, but really that is offloading providers and only interrupting when it's necessary. Next, please. So again, these alerts are pretty technically not difficult to make, but a lot of thought goes into them, and it's really important to get feedback from providers about them so that we make good alerts. Next, please. Here's an example of one that we've done in the emergency department that's now gone across the system. This was our previous intervention. You can see it's site 1 up there. That's the academic site. And we did a series of interventions ending up in the blue one, which was a mandated interruptive alert to look at the prescription drug monitoring program before prescribing an opioid. So an evidence-based practice and now becoming mandated in our state. And so pushing that into the workflow with an uneducated alert, the highest we got was 40%, but you can see at our community partners a little bit lower. And so less responsive, the same level of dissemination at all the sites. Next, please. So instead we said, well, what if we do this automatically? So if we push it in the workflow, people aren't responsive. What if we interpret them for them and then only push it in their workflow if they really need it? And this sort of very basic concept is what we've used to build our new one. Next, please, which is a lot more complex. So I just bring this up because we talk a lot about resources, and this is all the information that happens in the background, right? We need to find out how things are connect, where they live, validate that they exist, validate that we can pull from them for our logic. And then in that red box is actually where the CDS tool lives. And then on the right side, really important, and I'll talk about briefly at the end if we have time, but outcomes. So what are the outcomes of the action? How interruptive is it? Are the providers doing what we think they're going to do? Are we nudging them in the right direction? Are there unintended consequences? And how much increased clicks are we causing? Things like that are really important outcomes. Next, please. And this is some of the initial data from this one. So I told you previously at our sites, we were at sort of 10 to 40%, the best case scenario. This is after turning on our intelligent alert. This looks pretty scattered because these are daily, but in the first few weeks here, we are seeing a trend up. We even started higher than we left, and it seems to be that providers are responsive. While we would love to be at 100%, I will tell you that this is much higher than any other system. That sort of for the entire state, it's somewhere around 20%. So we've made significant progress, particularly with patients, prescriptions that are high risk. Next, please. And so what is the ask for the system? There's a significant need for investment to make these tools useful to our providers and to not lose providers. I'm particularly sensitive to turning out a bad tool and losing people right off the bat, feeling like they're never going to come back. So content creation is really an important resource to have available. That's expertise, that's the ability to test it in a practice environment, to get feedback on it before you turn it live. Analysis, right? I sort of talked about some of the outcomes, but is it doing what we want it to do? How do we get that data? And connect that to patient outcomes, most importantly. Is this process equated to the outcomes that we thought it would? Next, please. And then I mentioned outcomes. There's lots of different ways to look at decision support and how we deliver them and what the patient outcomes are. This is a whole conversation to itself, but the general takeaway is that CDS can nudge people to do the process, but we need to spend a lot more time making sure that those processes equate to delivering evidence-based practice. Next, please. And similar to OUD, I feel that this does the quad aim for healthcare. I think there's lots of benefits here for both providers, patients, and the system once we appropriately take advantage of CDS as an intervention implementation approach. Next, please. And that's it. That was a lot of stuff, and we got thrown behind. But I think I saw at least one question. So thank you. Thanks to everybody on our team for the help and the mentorship. Sarah, I don't know if you see other questions. I saw one.
Yeah, great. Thank you, Dr. Hoppe. If the group has any questions, please make sure that you put them into the chat box or even the QA function. I think one question did come through that function. So Dr. Hoppe, here's the question. In tracking the amount of opioids prescribed by providers, is there any distinction between full agonist prescribed for analgesia versus methadone bupe prescribed for OUD? I imagine it is a small factor, but could confound the data somewhat when looking at our prescribing practices as we treat more OUD with buprenorphine.
That's a great question and a big issue. So it depends who you're asking. If you're looking at the prescription drug monitoring program for the state, we actually take out buprenorphine, and methadone does not get reported to the prescription drug monitoring program, at least methadone for OUD. Methadone for chronic pain does. So to answer that question, it does not get counted. However, there's lots of, the further you dig into this, the more stigma you realize, but there's an issue with pharmacies. So pharmacies, the DEA tracks how many opioids a pharmacy dispenses. Some of that's earned because a lot of pharmacies made a lot of money during the opioid crisis in the worst years. And so the DEA actually does count buprenorphine, and that's an issue in rural areas. So in rural areas, if the pharmacy is the only pharmacy around and they think the DEA is gonna give them a hard time for giving out too much buprenorphine, they'll actually stop giving it out, which is an amazing that it's interpreted like that, but just sort of one example of some of the deeper issues here and policy issues that are really based in stigma. But for us, in general, what we look at within our system and within our state, they are treated separately for sure.
Are there any further questions from the group?
Everybody's ready to go prescribe buprenorphine, I can tell. I think they're all online getting their X-waiver.
It looks like we just got one. So what advice do you have for other investigators interested in embedded CDS and these informatics tools in a learning healthcare system?
That's a great question. So I would say there's a couple different levels of advice. One is to use the data that we do have to make sure that this is prioritized as a need for the system, which is one of the reasons I always start talking about the national need and then sort of whittle it down to the local need. So getting to the top of everyone's list. That also includes, I think, early stakeholder engagement. We always try and get our departmental support, our leadership support, operations, and then really have conversations early with the CDS teams. But there is a learning process. The governance process is definitely not a straight line. And so some of that is learning and anticipating. Some of that is getting the right partners. So I always partner with informatics support within our department so that they sort of know some of that. And then we've also now built a team of analysts that can do some of that. It is definitely a learning curve. The good news is once you have the resources and have some of that expertise, the following studies and implementation projects go a lot faster. But a lot of that's on the system as well. I mean, the system, to be honest, right, did not build EHR for this purpose. And while there's lots of efforts to improve CDS, there's always the opportunity to invest heavier and realize those quality and likely economic gains as well. So I would equally push outside of our department as well to make sure we have those resources available.
Great. Any last questions from the group?
Thanks for coming, everyone. Sorry for the trip in the beginning, and I kind of flew through it a little bit, but I'm happy to answer other questions. Please email me and let me know your thoughts about any of this. Thanks.
Thanks, Jason, and thanks, everyone. Thank you, Sarah. Have a great day, everyone.